Hey guys, Dr. Holly here. By now you guys are getting used to me coming on saying, hey guys, Dr. Holly here. Well, it's a pleasure doing these, and I enjoy doing these for you guys. I hope you guys are getting some good benefit out of them. We're going to talk a little bit about whiplash and injuries of the head and neck. Again, some of you guys may have taken my old one. This is a lot of slides from that and some new ones added. This year is for Mod 2, the MMT course on whiplash. And I'm going to breeze through this one here, and we're going to cover a lot of the things. Again, some of the physical exams we're going to be bringing over to these, and I'm going to show you kind of some of the applicable tests that we learned in our phys die class. So let's go ahead and get started. The initial statement. I forgot I put that up here, so let's lead into that. The MMT initial statement. Majority of people with whiplash improve within 1 month. Symptoms sometimes persist longer. This is true. I had a lot of people just get better on their own. They wouldn't do anything. Now the problem is the symptoms may go away initially, but man, I got to tell you, I've seen them come back a year, 2 years later with a lot more issues than if they had taken care of it in the beginning. Meaning, the cervical lordosis, the natural cervical lordosis was lost. They had degeneration going on. They were manifesting things going down the arms and hands. So it was all derived from the accident, but it's over a year to 5 years later, and there's no way that they could have that pay for treatment or get any remuneration from it. So they were kind of on their own. But yeah, some of the people will go ahead and just take some painkillers and it'll let it go away in about a month, and they'll go back to work. But it catches up to them later. Now, most therapists and doctors agree that the sooner massage or intervention is received, the quicker the person heals, and like this, especially this last one, and less likely to develop chronic neck pain or neck pain later. Okay. So just keep that in mind if you have someone that says, yeah, but it's getting better. Well, it will come on later, and I'm telling you, it'll get them when they're not expecting it or wanting them to. So keep that in mind if you're dealing with somebody. Some of the myths about whiplash, it changes the people's personality. There is no such thing as whiplash. It's just monetary gain, right? Illness and disability are biological phenomena. Men are more vulnerable than women. I gotta be honest with you, I don't know if it's more vulnerable. I'd say that we're more, gosh, I won't say accident prone, but if you're gonna have a guy jumping off of a bridge to impress a woman, you're gonna find more of those rebels in the male side. So yeah, I think you're more probably see more men, but oh, I almost said women are worse drivers than men, so you get more car accidents. So I'm not going to say that on the air or on a recorded thing. But you get your equal share of men and women. How's that? How's that? You also you also get direct impact upon neck is necessary for WAD, which is whiplash associative disorders. Okay, X-rays show nothing, so no WAD. Complaints are psychosomatic. They're making them up. Rest time, muscle relaxants, and tranquilizers can cure the distress. Seat belts would prevent the injury. If you just wear your seatbelt, you wouldn't get whiplash, right? Those are all common myths. Okay, so let's debunk those right now. None of those are true. Okay, what was the old joke? If on personality, I told one person. She kept saying that her husband was turned into a jerk because of whiplash, and he's right there. He goes, "I'm not." I mean, they were going back and forth in the exam room, and I said, "Look, ma'am, if he was an asshole before the auto accident and whiplash, then he's going to be an asshole now. It's not going to change him either way." So, just putting it bluntly, they kind of got a kick out of that. So, and she said, "Well, you might be right," but let's go ahead and move on a little bit here. There's different types of whiplash. There's, the forward and flexion and extension one. Then there's the rotational component one. And then there's actually the lateral whiplash. So there's a few different kinds of whiplash. Basically, any motion of the neck, you can get a whiplash type scenario going on. Now, I know some of you guys are like, what the heck would be a rotational whiplash? What would cause that? Well, just imagine if you have, I guess this picture right here would work. Imagine if that's the driver, the seatbelt's going to come over the the left shoulder down to the right side. So if they were hit on a front end, that side of the body is going to be anchored to the seat, and they would actually have a torsion going on, especially if they're hit over on the passenger front side. They could be whipped that way in a flexion rotation type injury. So you can get rotational ones. And any angle of the car, any angle, just opposite rotation would occur. So you can get rotational ones. Now, according to Dr. BB, PhD, pain, this here's following resistance test should be included when assessing whiplash. Pain upon restricted neck rotation or flexion indicates injury to the SCMs. Okay, so if you have restricted neck rotation or flexion, you normally have an injury to the SCMs, right? Now, of the side, pain would indicate you have injury to the scalenes. Upon extension would indicate injury to the posterior scalenes, the subox, and or the erector spinae. Okay, even possibly down to the traps and everything else. Depends on how severe it was. Not rocket science, to be honest with you, even though he's a PhD. Obviously, any direction of the head, the muscles in the opposite is going to be affected, and they can be causing pain by doing those. And you can elicit that pain by stressing those muscles with muscle testing. Okay. So what are some of the symptoms? Okay. Symptoms are and can be migraines, headaches, stiffness, neck pain, dizziness, nausea, and vomiting. Any of these things here can be result. They're secondary to the direct whiplash itself. Okay. What happens to the driver during a rear end collision? Okay. This here, if you have the head restraint, where a lot of people do, at the base of the skull, what happens is the body moves up depending on the angle of the backrest and the seatbelt or the adjuster. The body will move upward and the head jerks back, pushing the restraint down. You can see there's a gap right here, and on this there is no gap. It'll actually close it, so you're kind of going up and over. Now, this will really exacerbate the whiplash syndrome. You can imagine what happens here to all the platysma, all the frontal muscles, not to mention crushing the back facet joints and everything else. Then the head just doesn't stay this. It's going to go backwards, then it's going to whip even more so forward and restrain all the back muscles. So this is a rough one right here. So what are some of the facts on this? Do you have to be going fast? Even low speed, 5 mile an hour speeds can cause some significant injuries depending on where and how hard your car got hit. Your position in the car, the position of your head, the type of seat, the position of the headrest, your pre-accident medical condition. If you're an elderly, obese, sedentary person that doesn't get a lot of physical activity, you know, your body's not used to any type of trauma. Now, keep in mind also, only 12% of the persons who suffer from a whiplash are symptom-free after 10 years. It will stay on a long time, guys, if you don't get treated. Okay, this here's a study that was done. Okay, showed that 93% of all head restraints were suboptimally positioned. Okay, so what is a good head restraint? How high do we need to have this thing? The optimal height is to actually have it up to the top of the head. This, just look at the big one here. This here is where you should have the top of the head restraint up here. If it ends down here, it's acceptable. If it's below, mid or below the headrest, that's not acceptable. When you get in an accident, it's going to cause you, like a show, to go up and back, and it'll push it down more. Okay. Here's a better image of it. Right here, right near the top of the head. Now, it's not pushing her head forward. She normally isn't touching this when she's driving. This is not a good one. Okay. So keep that in mind. So if you see these, it's best, or if you have your kids in the car, say, hey, Johnny, little Johnny, put that headrest up and you measure them. Okay, that's what they're there for. That of all those crash dummy tests that these auto manufacturers do, this is what they've found out, that you get more severe trauma when it's mid or below the subocciput, the skull to the subocciput. If it's below that, you get a lot more trauma involved than it is if it's up level, mid, or up on the head. Okay. Again, it doesn't have to be, your head doesn't have to be against it. It just has to be there to catch it. Okay. This person, if she got in a wreck, God forbid, she would go just like the original one. She would go up and over, and she would have a pretty good, she would not feel good. She just wouldn't feel good. Okay. The mechanics, it's a hyperextension. Whiplash is really termed a hyperextension, hyperflexion. Okay. Majority of the cases, no direct injury, can be identified. Meaning, you're on a CT scan of the muscles, you're not going to see major tearing, hematomas, fractures. You're not going to see those because the majority of the cases aren't that severe enough to cause it. But on the other hand, that doesn't make them any less significant or painful or needing to be treated, all right? So the symptoms are more attributed to the musculoskeletal ligamental sprain, okay? Not so much a strain, but a sprain, right? So keep that in mind. Here, they did this, I want to say it was Croft. Croft has done a lot with Whiplash. I think he actually helped with this study too. The 6 phases of Whiplash. This is when the crash dummies first impact the thing or it impacts their car, and they measure, and they broke it down into phases. For the 0 to 60 milliseconds, they're just in the rest state. This is, it went boom, it just hit, and it hasn't really affected them yet. Bumper to bumper just hit, okay? 60 to 120 milliseconds. A millisecond is a thousandth of a second. They get 0.3 grams, 3 Gs, okay? The head starts to rise, neck flexion, and backbone extension, okay? Phase 3, 120 to 200, neck extension. Phase 4, head and neck hyperextension. We're going back up over the headrest, okay? We're up to, right here, we're at 4.3 Gs. We're going back, okay? Then it starts to level out, and we're in hyperextension. This is where injury starts to occur, okay? Now where it really starts is once it's gone to the max without ripping the head off, the head's going to whip back forward. Then it starts going forward with neck flexion. That's where your whiplash comes in the back of the neck. Because for years it was puzzling people. They get hit from the rear and the head would extend and go into hyperextension. Why is the back muscles all splinting? Because it was extended. They were shortening. Well, it's not the beginning stage that gets it. It's this stage, phase 5, where whiplash actually comes in. When it goes forward on the, I guess you can call it a rebound, when it goes on the rebound, okay? Then again, it goes back, and then it starts going back to the starting position. At that point, the damage has already occurred, okay? So that's the mechanics of whiplash. So whiplash doesn't occur in the beginning part of the motion. It occurs in the second part as it whips forward, okay? A rebound. You could also call, I guess, they haven't termed it, but I don't see why it would not work to call it a rebound injury, to be honest with you. Now, what would you do if you were going to work on a acute whiplash client? I can tell you the ones that we found doing things in this order, and you can actually go through sometimes all in the same visit, but we always started off with a static compression, a broad static compression over the back of the neck, and just holding it for a little bit and see if that really exacerbated the syndromes. We're not getting the little pointy fingers jabbing in there because they could be obviously very acute. So a broad contact with a light static compression or pressure will let them desensitize the touch. It'll also let you kind of know how much you can actually get in there on this first or second visit. Okay. And then we would go through a light myofascial release, some light stripping, maybe a light passive range of motion while we're doing this, all the while monitoring the patient's feedback, okay? Later, in some of the very, very minor ones, we could do some deep tissue, but again, you got to get the superficial muscles relaxed first, okay? That's when you get into the real meat and the potatoes, deep fascia adhesions, any scar tissue that, if it's been there for a little bit. You may need to work this for about 4 to 6 visits, and then later on in your visit plan start getting into the deep tissue. It all depends on the case, the severity, the mechanism of the accident, and the patient profile, okay? But on every one, I can tell you all our years, we've always started off with a static compression, light touch, broad stroke. Then we moved in, if we could, to the myofascial release, and then deep tissue. Now, we were a little bit more of an advantage, because what did we do if we couldn't even do static compression? I know someone out there is going to want to know that. So what we would do, if we couldn't even get hands on them right away, then we didn't do the massage. We didn't do any of the range of motion. What we did then is we did some E-stim and some ultrasound work for that visit or a couple visits until we could actually do this compression. Then we'd try this pattern again. Okay. Eventually we would get there. Okay. And then at home we would have them do contrast hydrotherapy, hot shower for a little bit, then cold shower. Switch it back and forth, hitting on the neck, or put a heating pad for 15 minutes, then let it off, let it rest for 5, then put an ice pack on it for 15 minutes. Let it rest for 5, then go back with the heat. You're causing dilation and constriction, and you're pumping some of the toxins in and out of the blood vessels in the spastic muscle. Okay, that really helped. And they'd also normally would take some anti-inflammatories, even over-the-counter Advil, to help with inflammation. That's what we would have them do for the first few visits if we couldn't even do static compression. Now again, always go cautious, because the neck, it's a lot more vulnerable than like a low back or everything else, or even with the whiplash patients, it's more vulnerable to a re-exacerbation because it's injured versus a wellness patient. So doing MMT type therapy, you got to keep that in mind. Now, since the anterior muscles are often injured in whiplash, be careful not to press on the nearby carotid. What this is in here for is because if they're already injured and spastic, there's not a lot of play in there. So if you start working on the muscles in the front, you could also start compressing on some of the carotids too, and start causing, I'm not going to say, I guess I'll say it's some form of a entrapment syndrome. Okay, so be careful of that. Wait until a few days after the accident before administering massage, so the initial healing process is uninterrupted. We never had them within a couple days of the accident. We always had them 3 to 5 days afterwards. That was our acute ones that we had in. Again, they were initial, if they happened that morning, that night, they normally weren't hurting that bad. About the 3-day window is when it really starts hurting, and their upper back, their low back, everything starts hurting then. About 3 to 5 days, they're really starting to ache. That's when it's really coming on, okay? Again, if one comes to you as the portal of entry, I would always refer to a physician to get an x-ray, make sure there is no fracture, no dislocations, anything like that, okay? And again, just keep in mind, do no harm. As doing MMT on these guys, just make sure that you always go slow and cautious enough at first not to cause any re-exacerbation. That's all. Stages of injury, just in case you guys don't remember these. Stage 1, this is textbook. It's not real world. Textbook is black and white. Real world is gray. But this is a guideline, meaning that not everybody fits in this in the real world, but it's kind of a guideline to go by. The acute, up to 72 hours. The subacute, it can go up to 14 weeks. Depends on, let me give you an example. If we have a subacute one, they're in the repair phase, but they do have to work to make a living, and they're standing at an assembly line all day long doing repetitive stress on their already injured body part. It's going to take a long time to heal, so they can be in the subacute up to 14 weeks. Remodeling, normally after 12 to 14 weeks or on. That's the remodeling phase. Normally you're going to get them right in the subacute. That's when 99% of your patients are going to come in. If they come in the acute phase, you need to do a little assessment and then refer them to get a clearance, I'm going to say. That would be my advice. Then obviously chronic, it's been there a long time. Then you're dealing with, you're dealing with a lot of stuff. Scar tissue adhesions, probably some erosions, a little bit of everything when you're dealing with this. Grades of severity or injury, okay? Grade 1 through 5. Minimal is no limitation of motion, no ligament injury, no neurological findings. So their muscle tests are coming back okay. They got good reflexes. They can turn their head left and right, up and down with no problems. That would be a grade 1. Grade 2, it hurts a little bit to look to the left, and it hurts a little bit to go to the right, so I'm not getting my full range of motion. That would be a limitation of motion, even though there's no ligament or neurological findings. That would be a grade 2. Moderate, grade 3, you got some limitation again, and you might have some ligamentous injury. Those could be definitely determined with a CT scan. You can actually look at if it's a lateral translation, and I think I have an image a little bit later. You really suspect ligamentous injury, and their muscle is weak on one side versus the other. You may have some neurological. They don't have a good reflex, things like that. And again, grade 5 and grade 4 and grade 5, it just gets worse and worse. Okay, I doubt you're going to be treating. Unless it's a direct referral or co-treatment, a grade 4 and definitely not a grade 5. Okay, so you'll probably be seeing grade 2 and a couple grade 3s is what's going to be coming in. You may even see grade 1s, even depends on the nature of the condition or the accident. This here is a guideline for the Croft. Dr. Croft is a specialist in whiplash and trauma care, and he has done numerous studies, and now a lot of the auto insurers, the insurance carriers, actually use what's called the Croft guidelines when approving care. We always use them every time we did a new patient, we're billing through the auto accident. We used the Croft guidelines based off our exam on how many visits we're going to see them. And I would actually show the guidelines to the patients, how many times we would need to see them. We would do the exam. A lot of them would be right through here. I'm going to say 80%, 85%, almost about 85%, 80 to 85, fell into a grade 2 that would come into our offices. So we would have a grade 2. We would skip grade 1. We go right to grade 2. Grade 2, this is the schedule that they would actually do. So they could go, this is the schedule, how many times. Now they say daily. I never did the daily one. That was just too much in my opinion. But we did the week. We skipped the daily part and we went right to the week. So we went 3 to 4 times a week, 2 times a week for 4 weeks, then 1 time a week for 4 weeks, then 1 time a month for 4 months. Total duration between 29 and 33 visits is what they would get. We never got denied. We always sent this form in with our proposals, and they understood that. Our massage therapy didn't do it all this long. This was for our chiropractic and physical therapy. The massage therapy used these as the guideline. They would actually cut it in half with massage because we're doing everything else. And they followed this guideline, but they just cut it in half. And they also used the previous guideline to tell them where they're at. Okay, that's how they determine what grade. So it's very helpful to have the Croft guidelines. Rewritten, what is a grade 1? Just to make sure you guys know, I typed this in. This is my own words. Grade 1, complaints of pain in the neck, stiffness or tenderness only, but No physical signs. They're doing all right by the examining physician. None were present. Grade 2, kind of neck complaints. The physician finds a decreased range of motion and point tenderness. That would be a grade 2. Grade 3, definite decreased range of motion. Some neurological signs, deep tendon reflexes, weakness. They can't sleep at night. Some sensory deficits. You take a Q-tip, rub on the back of their hand. Can you feel this? Can you feel this? No. Well, they got some things like that. It's a sensory deficit. Then obviously grade 4, you're definitely referring out. We never even mess with those. Okay. So that was rewritten in my words. There's also, metaphorically speaking, a hot and a cold whiplash, and you can think of it as hot and cold. Oops, hit the button too soon. A recent whiplash, which is less than a month, we always termed a hot. It's still in the acute whiplash stage. It's a hot whiplash. Cold whiplash is older. They can also turn hot really quick if you overwork it. Give you an example. We had one that a post MVA came into our office. We did some light adjusting. This was about, I'm going to say it was about 12 months post motor vehicle accident. We did some light adjusting and they were doing good. We did some light massage work. They were doing good. About 4 treatments of that, no problem. They're getting more range of motion. At that point, they really don't have pain. They have limited range of motion. But then we went a little too quick because the patient was doing good, and we started doing resistance exercise right away and started putting them through some heavy physical therapy. Well, it re-exacerbated almost to a full-blown whiplash, and we started them back at stage 1, and they got back to normal with their baseline normal really quick within about 3-4 visits. But then we just took it a lot easier. We did instead of direct resistive exercises, we did assistive exercises, and then we did active assist, and then we did active, and then we did active resistance. Okay, we took it in some stair steps, and that's what they needed. Then we got them on the right path, and they were fine. So, lesson learned: you can really, really quickly re-exacerbate a cold whiplash and make it a hot whiplash, even though it's not acute. You can get the hot symptom or the acute symptoms reenacted really quick if you're not careful. So always use caution, even if someone says, it's a post-whiplash about a year ago. Easier to go 1 step slow forward than 2 steps backward fast. Okay. The hot whiplash, distinguished by being sensitive, fragile, and reactive. Key word there, as a flight or fight with the autonomic, right? The head and neck are typically immobilized by a muscle spasm. They're really prone to get spasms, especially at nighttime. We've had a couple of these happen to us, and they said when they're sleeping, at night, their neck just seemed to freeze up on them. Okay, keep that in mind. That's the other thing. The tissue in the injured areas will feel softer or puffy. Normal muscle tone. You guys are experts at feeling muscle tone in individuals. This here won't have, the hot whiplash won't have the normal muscle tone, the tonicity. It's not spasm, but it's just a tone to it. It normally doesn't. It just feels totally flaccid, or like I said, it's puffy. They may guard to the touch, even though it's puffy. You start poking, they may start tightening up and guarding, uneasiness or pain, which increases the sympathetic. You're really playing with the sympathetic system here when you're dealing with a hot whiplash. So keep that in mind as you're going through these. If you have one that's about 6 months or more, and you start just doing some general palpation on the area, and it feels just really soft and puffy, you're probably looking at a hot whiplash, so you want to be cautious, okay, if it doesn't have the normal tone. Especially, it can even have different tone on one side or the other, okay? The left may feel normal, and the right may feel really off. Use your gut and just kind of go slow on that one, okay? Cold whiplash, normally older, less autonomically reactive and restricted at the ligamentous joint level, okay, as opposed to muscularly spasmed. If spasmed is a word. I did a spell check and it didn't recognize it, but it didn't say it was wrong, so I just went with it. It's the little things in life that trip me up. Basically, the cold ones, it's going to just feel more just stiff, rigid, dense around the joints. Whereas, again, hot whiplash often becomes cold once initial tissue damage has begun to heal. Okay. Um, Again, cold can become hot if worked too quickly or aggressively. Just keep that in mind. Working with hot, your primary goal is to calm the client's autonomic system before trying to work any tissue restrictions. Again, that's why I like the broad contact and working with them a little bit better. Imagine you're working on an unprotected CNS, central nervous system. In a way, you are really after a traumatic event, right? So how would you touch a client who is nothing but a bare brain in the spinal cord? Obviously very delicately and carefully. So dealing with the hot, even though it may not be acute, it's still considered a hot. So keep that in mind, okay? Again, pace your work. A lot of times, even if you're doing a gentle touch, I've seen some of the therapists in our clinic do this. They're doing very gentle strokes, but they start doing things fast, or they're having them flip on their back, on their sides. They're doing things. You got to be careful on that. Or they're doing too long of a sessions. We started noticing this years ago that sometimes the 40-minute to 60-minute sessions weren't effective on these as a 30-minute session, little short mini ones. This got a lot better overall reactions. That's why you've seen in some of my care plans that I advise doing now, I advise doing a lot of mini 30-minute ones to have the clients come in. It just seems to work better for them, okay? So keep that in mind. Again, as they get better at this, they start to heal more, and you're working with them, then you can gradually increase the duration and depth and intensity, I'll say. So, okay, again, you can always work a little more next time, but it's hard to take back your work once you've already done too much, okay? Easier to go forward than have to stop and go backward and recover. So what would a generic care program be? Going by the Croft guidelines, this is some of the things that we've done. We'll do our initial assessment. We'll do 2 to 3 times a week for a couple weeks. Normally we do it about 30 minutes. We don't want to overdo it for the reasons that I've just said. If they're doing good, meaning they're sleeping better at night, you did a good history. They're sleeping better at night. They're able to get more range of motion. They're doing better. Their pain level's dropping every time they come in to see you. Then we'll bump them down to once a week and see how they do for a couple weeks. And we may even increase it to 45 minutes. Doing good on that? Great. We'll do it just once a week for 4 weeks for 30 to 45 minutes. Let me see. Hold on. That was a misprint, guys. That should be 2 times a week for 2 weeks. Then once a week. I will change that in the notes. Actually, let me do that right now. Let me see if I can do this. I don't think I can. I was going to try to change that on the fly, but I can't right now. So the initial assessment should be there, the 2 to 3 week for 2 to 3 weeks. Then it should be 2 times a week for 2 weeks. And then 1 time a week for 4 weeks. Okay. Then once they've done through that and they're doing pretty good, then you can go into a wellness. They're going to love you. They're going to be used to coming in anyways. Then you can do the wellness. I would recommend doing twice a month at 60 for the first month, and then do once a month at 60. Then have them come on in, whatever you feel is beneficial to them. Okay. So keep in mind again, when I typed this the other day, I meant to put it 2 times a week. So scratch that in your notes and just put it 2 times a week for 2 weeks, and then 1 time a week. Okay. Always check. This test looks familiar to you guys, or at least, good Lord, I hope by now it does. You guys are going to be masters at these. You guys are going to be wanting to do these tests so much, you guys are going to come in with a big toe problem. You're going to automatically tell them to raise their arm up, right? Again, any type of a whiplash, obviously, the neck is injured. To the patient's comfort, you want to try to get them to raise up. A lot of times they can't if it's acute. So this could be a benchmark sign. Maybe they could only raise their arm up to a 45-degree level instead of a 90-degree level. That's fine. Just mark it in the notes. Following week, test it again after you've had 2 or 3 treatments. You'll probably find they could get it up 3/4 of the way. After another week, you'll be able to find they can get it up all the way. Okay, you're setting benchmarks and monitoring. Okay, and again, if they can only get it up halfway, don't even bother trying to resist it. That's as much as they can do. If you have to, lay them on their back and do it without gravity if you want resistance. But if they have a whiplash and they can only lift it about halfway, I never bothered trying to do resistance. They weren't ready. I waited till they can get it all the way up and hold it. Then I would do a light resistance and compare bilaterally. Okay? Just because of the nature, you're dealing with possible plexus injuries, always check. You'd be surprised at the people that we have done these on, and they would have a big discrepancy on one side versus the other. You automatically check the range of motion of the head and neck. You do the deltoid, and then you also do the biceps. You'd be surprised of the discrepancies. So keep that. I'm not going to go into this, you guys. I'm beating this one to death, these upper exams, which is true. You need to know these because they really give a good baseline. And hopefully you guys are seeing how applicable these are to multiple conditions. It gives you a good baseline to monitor these guys through. Okay? Let's talk about lateral whiplash. Okay, the deepest soft tissue structures of the neck, such as the zygapophyseal or facet joint capsules and ligaments, can be a primary source of pain and movement after whiplash has occurred. Once inflammation has settled, restoring mobility can provide significant relief. What's a good way to see if we have joint involvement? Again, the compression in the Jacksons. Laterally tilt, you're stressing the zygapophyseal, these joints, stressing the side to see if they're impacted. If it is, then you got a little bit of work to do. You want to be able to monitor at what angle, how much pressure, everything else did it cause the response as you're working and restoring range of motion and doing passive stretching on these people. Okay, same thing with the shoulder depression. If we crimp it on this side, if we do a Jackson's and we bend it, it hurts. Then if we open it up, it feels better. Then you're dealing with a joint. Okay, if it doesn't hurt on a Jackson's, but we stretch it and it hurts on the stretch, then you're dealing with tight muscles or plexus entrapment or a dural sleeve adhesion, something else, soft tissue. Okay, so again, we've gone over these at nauseum. I don't want to keep belaboring those, but these are very, very applicable tests with these. And same thing with the cervical distraction. What you'll find is most whiplash, unless there's more chronic in nature, the more acute or hot ones, this won't help. They'll see no change or it'll exacerbate a little bit. The more chronic ones, this will take relief a little bit. Reason being is because the muscles are still splinting. They're still tight and spastic in the acute and in the hot. So whenever you go to lift up, you're stretching an already tight muscle. So it's going to cause more of a guarding reflex. It's going to hurt more. Whereas the chronic ones, they've had a tight muscle pulling down on them so long, they're already getting inflammation around the joints. So when you lift up, you're opening those joints and you're taking pressure off. So that'll give you an idea too if it's more acute, hot versus chronic. And again, you're not trying to dislocate the head. It's a nice, slow, steady, about 5 pounds upward. And you're just holding it and asking them their response, okay? What is lateral translation for like lateral whiplash? This is a good image right here on the right. Basically, you'll have them stand and look at you when you do your posture assessment. And if you see, it should be a midline, nose over the episternal notch, down the breastbone, should be the nose and the mouth right straight down. Well, obviously, this girl is off to the right, laterally translated. Her head's not tilted, it's just translated, shifted left, shifted right, okay? So if she was in an auto accident, I would suspect that there may be some ligament damage, and I would probably send her for a CT to confirm, and then I would do my treatment plan according to the Croft guidelines. So she would be a category what? I heard a few of you guys mentally say 3. She would be a category 3. Okay. Um, if you have one of these, it's good to send out to get x-rays and let the attending doctor decide if they need a CT scan to look at the stuff, or an MRI to look at the soft tissues, okay? So again, persons suffering from a lateral translation after an incident or such as whiplash are highly suspect of ligament damage, okay? So just keep that in mind when you're dealing with these. So you may ask, well, what do we do on that? You know, if you get cleared to work with them, one of the things, a Pedibond type procedure is to have them block against the wall. Our massage therapists would do all the muscle work, soft tissue work, get them all loose and warm, and then we would immediately have them stand up and laterally, not bend the head, but laterally translate their head in the opposite direction. This would start retraining those ligaments to go back to normal. After about 3 weeks, 4 weeks of this, the head will actually start going back. But the key thing is to do it when it's hot. Things bend better and remold better when they're warm, i.e., massage therapy, getting in there, doing passive stretching, then working all the tissues, and immediately getting off the table and going up and standing for 60 seconds, just like that. Now, sometimes we actually broke it up. We'd have them warm it up, stand for 60, then we would have them go back on the table, work the muscle, stretch it for a minute to 2 minutes, go back up and do another 60 seconds. We would do that 4 or 5 times, okay? That would be the whole treatment session. And again, after 3 to 4 weeks of coming in a few times a week and then doing this, you could actually re-see. In difficult cases, you could actually put a head weight on. You could do more advanced things, but that's for more of a scoliosis and posture correction thing rather than what we're dealing with as an MMT program. So that will get you far just in that. Brain injuries, obviously it's a soft tissue inside of a bucket, right? A hard bucket. So you get coop and contracoop lesions, concussions, intracranial hematoma, epidural, intracerebral, and subdural, and diffuse axonal injury. Basically all brain injuries. Some blood vessel problems through here with the hematomas. So what are some of these things and how are they accessed? All right, post-accident amnesia, memory problems when regaining consciousness. You know, what's your name? Heck, I don't know. Do you know you're in an auto accident? No, I thought I was in bed. You know, memory problems when regaining consciousness right after the injury. Minor brain injury, we always ask the patient, were you conscious or unconscious? And you can always verify that by a police report or accident report as well. But we always ask them, were you conscious? Were you knocked unconscious? Did you hit your head on the dash? Anything like that. If they're unconscious for less than 15 minutes, you know, not that big of a deal. It's a minor brain injury. Moderate, more than 15 minutes, but less than 6 hours. Okay. Severe, hold on, hit the wrong button. Severe, over 6 hours. These guys here, we're probably not going to be working on, okay, to be honest with you. You're going to be getting most all of them right here. That was 99% of our cases. Some got knocked unconscious, but they came right back too. We never really, I recall maybe in all my years seeing a handful that were over this. I didn't see any of these. If we did, they weren't referred to us and we didn't treat them. We just didn't have them in. So most of yours are going to be on this. You know, obviously if you're going to be doing a brain injury, you're going to be going for CT scan, EEG testing, and everything else. An electrical encephalograph testing. Now, the pathophysiology, a sprain. The majority of whiplash injuries arise in soft tissue injury to the neck involving ligaments, joints, capsules, muscle, and tendons. Again, injuries at the microscopic level without altering structure. What I'm saying here is most all the cases that we're going to be seeing on our table is going to be right around here. Type 1, and it's going to be soft tissue. Those are the ones we're going to be dealing with. You may come across a few that have a partial tear, and you're going to notice those with limited, different range of motion, different end feels. The lateral translations, you may see a few of those. 3, you're really not going to be seeing 3s, okay? So keep in mind that's the pathophysiology of a sprain. You can actually tear severe sprains. You can actually get some severe tearing with separation of tissues. You're probably not going to be seeing these. If you do, you're going to be under direct supervision and co-treating with a physician, physical therapist, physiotherapist. That's what I would advise doing also. That way they can, if they needed to order the test, and it's, when I say that, it's not because of competence. Believe me, I've seen many massage therapists that know a hell of a lot more than some of the doctors out there. But it's because of liability and the ordering capabilities. If something doesn't go right, we don't have, or you guys don't have the mechanism to order an MRI, a CT, an ultrasound to see what's going on. Okay, you don't have that mechanism to do that. You have to refer anyway. So it's always better if you get someone like that to definitely directly work with someone or co-treat. Okay. The WAD, the Whiplash Associated Disorder. Let's talk about that for a little bit. 0 to 4. This here is caused by severity of signs and symptoms, complaints but no physical signs. Almost like the original Croft guidelines if you look at this. Okay. Again, low impact collisions. This here is the escalated symptoms from WAD. If they have this type of an injury, you can suspect with a WAD they may have some of these side effects. Okay, any of these things here, and I'm not going to read all these to you guys, but this here's some of the conditions that they may have. Okay, that's where some of the myths came in, that the personality changes. Well, the personality doesn't, but you may have poor sleep because of these things, which is going to probably make anybody grumpy, but it won't change personality directly. So this here is some of the symptoms that may come on because of WAD. Studies show little or no efficacy of treatments. This year is the Quebec back in '95. Collar and NSAIDs on short term. Avoid long-term physiotherapy. Mobilization by trained person and active exercise for grades 2 and 3. Remember the grades 2 and 3s, right? Drugs, early return activities to promote mobility. This year was a study on the treatment efficacy for not using massage, just using traditional medical treatments and not doing manipulations unless they were by a trained person and in active exercise for a grade 2 and 3. Okay, and what they found is most studies that do those without massage and soft tissue work showed little or no efficacy of the treatments. They don't work. Well, duh, it's because most whiplash injuries affect the soft tissue. Very few will actually affect the bones. Okay, so keep in mind, this study is saying that, but it's not saying that. Okay, so massage is highly effective for whiplash. Okay, WAD patients, the whiplash disorder ones are 2 times more sensitive to cold. I've had a lot of them come in during the winter time, and the wind, whenever we'd have a cold front come in, it would make the symptoms worse. They would actually, we would get them on a pain scale. We'd see them be dropping all the way through our visits. They'd go from an 8 to a 7 to a 5. Then all of a sudden the cold front comes in, they're back up to an 8 again. So don't let that discourage you. But sometimes cold will actually cause these things. And again, sometimes heat or vibration can affect them. I haven't seen anything. Normally I've found in chronic ones, heat helps more. So keep that in mind. Again, if you guys won't be doing any electrical stimulus like e-stim or anything like that, but I wanted to put this in here because just to let you know, even with us as chiros and physical therapy, we have to be careful for interferential and e-stim and all that stuff, because you really can't put a whole lot of stimulus in the whiplash patients. Okay, and again, hypersensitivity to peripheral stimulation. Okay, I've even seen some that were more hypersensitive to smells after the whiplash. So keep that in mind if you have a whiplash patient coming in. And some of them were more for like peppermint versus lavender. It was kind of different. So you got to play it by ear. Okay, everyone's going to be a little different. Now, I'm not going to belabor this one too much. The everyday living, buttoning shirts, putting on shoes, things like that. They were a lot higher in WAD, whiplash associated disorder, with whiplash patients. Chronic had a high stress load. This here was more physical problems. Then later in the chronic ones down here, it got to be more internal stress. They were frustrated quick. Okay. WAD patients, especially those with a low educational level, appeared to be more vulnerable and react with more distress than healthy people. So if you have, I'm not going to say to degrade anybody, but if you have one that's high school dropout, that's obese, sedentary, and doesn't do anything, they're going to be more prone to have a negative outlook and have more stress and be more reactive than you will with an educated person or a athlete prior to getting in a car wreck. Okay, so keep that in mind. Don't let those phase your clinical decision making. Okay. Depression and anxiety 2 years before an accident significantly overlaps with whiplash patients. So if someone is a depressed individual or their hyperanxiety before they get in an accident, at least even 2 years before, up to 2 years before, it will definitely overlap and magnify the pre-existing conditions. Like I told the lady, if he was an asshole before, he's going to be an asshole now, right? Forgive my French, but that's kind of what I was saying. Whatever you were before, it's going to be magnified more sometimes. So keep that in mind, and it's not going to change personalities on you. Depression and anxiety were greater in WAD patients than control patients in research. Lee et al. 93. Longest history, gave the highest ratings. And, I'm not going to read all these to you, but anything basically a post-whiplash injury, they're more susceptible to agitation, stress, anything else that can happen. And if they're like that, high-strung type A personality before the whiplash accident, they're going to be just like that, if not more so, and more easily set off following the accident. And that can happen 2 to 5 years down the road even. That's where I think the myth came in of a personality change, to be honest with you. That's where I think that came in over the years. So that is the end of the Whiplash Mod 2 MMT course. I hope you guys got some good tips out of that and aren't. I've had a lot of emails from massage therapists over the years saying, we normally don't do any whiplash patients because we really don't want. We're used to working for wellness and we don't want to do these. So I hope if you're one of those, this will open the door for you to not be afraid or concerned, but just go on in and treat them like a normal one, but use different guidelines and refer back to this as often as you need. So again, the purpose of this course that we're doing is to introduce those into a new realm of treatments, so, and open the door for new patients. So anyways, I hope you guys enjoyed. I love doing these for you guys. So that's it. I'm going to sign off, and I'll see you on the next one.